The concept mobility will include the exemplars hip fracture, disuse syndrome, joint replacement, osteoarthritis, and osteoporosis. We will discuss a few of these. The exemplar joint replacement is under the category of the mobility concept. Patients with severe joint pain and disability may undergo joint replacement. Conditions contributing to joint degeneration include osteoarthritis, rheumatoid arthritis, trauma, and congenital deformity. Some fractures, like a fracture of the femoral neck fracture, may cause disruption of the blood supply and subsequent death of tissue due to insufficient blood supply, which is called avascular necrosis. It also has to do with management with joint replacement may be elected over an open reduction. Joints frequently replaced include the hip, knee, and finger joints. More complex joints like the shoulder, elbow, wrist, and ankle are replaced less frequently. Nursing interventions when there is a joint replacement has to do with assessment of the patient and preoperative management. Those are aimed at having the patient in optimal health at the time of surgery. Nursing interventions also include preventing deep vein thrombosis. Patients having orthopedic surgery are particularly at risk for deep vein thrombosis and pulmonary embolism. The use of medications that increase the risk of clotting, such as certain hormones and NSAID drugs, may be discontinued a week before surgery. Assessing the neurovascular status of the extremity undergoing the joint replacement is important because post-operative assessment data are compared with pre-operative assessment data to identify changes and any arterial impairment to the affected extremity. Another nursing intervention is preventing infection. Any infection presenting 2 to 4 weeks before planned surgery may result in postponement of a surgery. Preoperative skin preparation, such as showers with antiseptic soap, frequently begins 1 or 2 days before the surgery. Culturing of the joint during surgery may be important in identifying and treating subsequent infections. The other intervention is managing pain. Assessment of the patient's pain preoperatively and any cultural and value preference are important components related to the control of pain following joint surgery. Assessing the patient's level of understanding of surgery and explaining what to expect can improve outcomes. A patient receiving total hip arthroplasty or hip replacement has many nursing diagnoses and nursing interventions. There is Chart 41-8, Plan of Nursing Care, in your Hinkle ebook, page 1119. Our nursing interventions would include assessing the patient for pain, asking the patient to describe that discomfort, and using pain-modifying techniques, after which we evaluate and record the discomfort. Also, nursing interventions that are included are maintaining proper position of the hip joint, which would be abduction, neutral rotation with limited flexion. We want to keep pressure off the heel. We want to instruct and assist in position changes and transfers. We offer encouragement and support exercise regimen. Also included is monitoring vital signs and observing for shock. We want to prevent hemorrhage or be aware if it is starting to happen. We note character and amount of drainage, and we notify the surgeon if the patient develops shock or excessive bleeding, and we prepare to administer fluids or blood component therapy and medications. We also monitor the hemoglobin and hematocrit values. We assess our neurovascular. We assess the extremity for color and temp, cap refill, edema, swelling, elevate the lower extremity, assess for deep throbbing, assess for pain on passive flexion, assess for change in sensation and numbness, and assess ability to move the foot and toes, assessing pedal pulses on both feet, and notifying the surgeon if altered neurovascular status is noted. The exemplar osteoarthritis is a degenerative joint disease. Osteoarthritis is a non-inflammatory degenerative disorder of the joints. It is the most common form of joint disease and is routinely referred to as a degenerative joint disease. It is classified as either primary, which is idiopathic, with no prior event or disease related to the osteoarthritis or secondary resulting from previous joint injury or inflammatory disease, similar to rheumatoid arthritis. Unlike most of the disease processes, the pathophysiology of primary osteoarthritis does not involve autoimmunity or inflammation. It can occur as the end result of an autoimmune disorder where joint destruction occurs. Another distinguishing characteristic is that it's limited to the affected joints. There are no systemic symptoms associated with it. Osteoarthritis often begins in the third decade of life and peaks between the fifth and sixth decades. By 40 years of age, 90% of the population has degenerative joint changes in their weight-bearing joints, even though clinical symptoms are usually absent. Women, especially those who are Hispanic or African American, are more commonly affected. The prevalence of osteoarthritis is between 50 to 80% in older adults. Although osteoarthritis is usually thought of as a disease of aging, it also affects younger patients and results in significant losses in work-related productivity and higher costs. Now, the pathophysiology is all joints consist of bone, to which articular cartilage is attached. This articular cartilage is lubricated and smooth tissue that protects the bone from damage with physical activity. Between the articular cartilage of the bones forming the joint is a space called the joint space that allows for movement. To aid in the fluidity, each joint contains synovial fluid to help lubricate and protect the joint's movement. Now, with osteoarthritis, the articular cartilage breaks down, leading to progressive changes to the underlying bone and eventual formation of bone spurs or osteophytes that protrude into the joint space. The result is that the joint space is narrowed, leading to decreased joint movement and the potential for more damage. The clinical manifestations are pain, stiffness, and functional impairment. The joint pain is usually aggravated by movement or exercise and relieved by rest. On physical exam, the affected joint may be enlarged with a decreased range of motion. Although osteoarthritis occurs most often in weight-bearing joints like the hips, knees, cervical, and lumbar spine, joints are also involved, causing bony enlargements. Crepitus may be palpated, especially over the knee. Joint effusion, a sign of inflammation, is usually mild, and no systemic manifestations are found. Medical management are to decrease pain and stiffness and to maintain or, when possible, improve joint mobility. Exercise has been found to prevent osteoarthritis progression and decrease symptoms. Along with exercise, weight loss, which in turn decreases excess load on the joint, can also be extremely beneficial. Occupational and physical therapy can help the patient. The exemplar osteoporosis is a metabolic bone disorder. It is the most prevalent bone disease in the world. The consequence of osteoporosis is bone fracture. It is projected that 1 of every 2 Caucasian women and 1 of every 5 men will have osteoporosis-related fractures at some point in their lives. Now, prevention can be essential. Peak adult bone mass is achieved between the ages of 18 and 25 years in both men and women and is affected by genetic factors, nutrition, physical activity, medications, endocrine status, and general health. Now, risk factors for osteoporosis and their effects on bone remodeling and maintenance are noted. Primary osteoporosis occurs in women after menopause, usually by age 51, and in men later in life. Failure to develop optimal peak bone mass and low vitamin D levels contributes to the development of osteopenia without associated bone loss. Early identification of at-risk teenagers and young adults, increased calcium and vitamin D intake, participation in regular weight-bearing exercise, and a modification of lifestyle, which includes reduced use of caffeine, cigarettes, carbonated soft drinks, and alcohol, are interventions that decrease the risk of fractures and associated disability later in life. There is a chart in your textbook, 1141 page, chart 42-6, that discusses preventative measures for osteoporosis. Preventative home care checklist measures can include listing that risk factor, identifying calcium and vitamin D rich foods, consuming diet with adequate calcium, engaging in weight-bearing exercising daily, and once again, those modifying lifestyle choices to avoid that smoking, alcohol, caffeine, and carbonated beverages. Now, menopausal and postmenopausal women, in addition to what we just discussed, may have to have calcium supplements, continue to engage in exercise and improve balance, demonstrate good body mechanics, have pharmacological agents to maintain and enhance bone mass, and assess home environment for hazards contributing to falls. Now, men, we need to list risk factors associated with osteoporosis in men, including medications like corticosteroids, anti-seizure medications, and aluminum-containing antacids, also chronic diseases like kidney, lung, and GI, and undiagnosed low testosterone levels. They need to talk with primary provider about the use of medications to enhance bone mass or to correct testosterone deficiency. Within the concept teamwork and collaboration, plan of care is exemplar. The plan of care exemplar has to do with the nursing process. The nursing process is a deliberate problem-solving approach for meeting people's healthcare and nursing needs. Although the steps of the nursing process have been stated in various ways by different writers, the common components are assessment, diagnosis, planning, implementation, and intervention. For assessment, this is a systematic collection of data that will be used in the nursing process to determine the patient's health status and any actual or potential health problems. The diagnosis is an identification, whether it be an actual or potential health problem that could be managed by independent nursing interventions. There is also collaborative problems. Those are certain physiologic complications that nurses monitor to detect onset or changes in status. Nurses manage collaborative problems using physician-prescribed and nurse-prescribed interventions to minimize the complications of the events. The third step is planning. Development of goals and outcomes, as well as a plan of care designed to assist the patient in resolving the diagnosed problems and achieving the identified goals and desired outcomes. So this step is also called where we find our goals or our outcomes. The fourth step is implementation. Actualization or carrying out the plan of care through nursing interventions. And the last part of the nursing process is the evaluation, which is the determination of the patient's response to the nursing interventions and the extent to which the outcomes have been achieved.
Okay, so that brings us to acid-base balance, and I think students have really understood this, but anyway, there's three components to the acid-base balance. There's the pH, the CO2, and the bicarb. Okay? The biggest thing that you want to make sure that you understand about acid-base balance is that they're the two systems of the body that are most valuable for regulation are the respiratory and the renal functioning. Okay? So if there's any alterations in the respiratory or renal, we're more than likely going to see an alteration in our acid-base balance. Okay, so an acid is primarily all the hydrogen ions. Okay? A base is a substance that binds to the hydrogen to make water, and the buffer prevents any major changes in the extracellular fluid. Okay? So basically what we want is we want a neutral environment. We don't want it too acidic and we don't want it too alkalytic. Okay? So we want to maintain it with parameters. So how do we do that? We do that by using our two systems, the lungs and the kidneys. Just like when we talked about with shock, we said that because the kidneys shut down, we're not reabsorbing sodium, the sodium bicarb, so that puts us in metabolic acidosis. So this just kind of reinforces this because this is an exemplar of metabolic acidosis would be shock. Okay? Lungs would be the regulators for the CO2 component. Okay? So our lungs help just by increasing or decreasing the rate of respiration to regulate the amount of CO2 in our blood. So the physiological buffers for each component are the lungs and the renal ability. The lungs help regulate the acid component of the part of the pH balance. So pretty much the lungs are associated with the CO2. How do the lungs help? Well, they either increase or decrease the rate of breathing. So they'll either breathe slower or deeper in response to the pH. Okay? So that is pretty much how the lungs compensate. Renal, what will happen is if, for example, there's an excessive amount or too little amount, it will either help by excreting the amount of bicarb or help so the kidneys can either produce or excrete the bicarb of whatever is needed. So pretty much they're like the regulatory systems of the body to maintain pH balance. And SaO2 tells you the oxygenation in pulsons, by pulsons. Okay, so I'm not going to review this again, but the steps for blood gas interpretation, you need to identify if it's acidotic or alkalotic. So anything below 7.35 is acidosis, and anything greater than 7.45 is alkalosis. So big thing with this is that when we look and we identify if it's acidosis or alkalosis, then we need to look at our PaCO2 and then our bicarb. And whichever one is altered, we'll look at it, and we have to look at the direction that each component is going. So for example, if I have a low pH and a low bicarb, then I know that it's a metabolic issue because it's going in the same direction. If I had a low pH and a high CO2, then I know that it's a respiratory component. Okay, so we need to look and make sure first at each piece and identify acidosis or alkalosis, and then look at the bicarb and the PCO2 and see which one is affected and what direction it's going. And so a good acronym that you can use is ROAM. Respiratory moves in opposite direction of pH. Okay? So just think of that, and then you'll always remember. Respiratory alkalosis is when the pH is high and the PaCO2 is low. So when the PaCO2 is low, that means that there's not enough CO2 in the blood. So when we think of patients that are anxious, they're hyperventilating, okay? So a lot of times they're breathing so fast that they're getting rid of all the CO2. So when that happens, usually we'll see it with patients that are anxious, they're hypoxemia, they've had like a salicylate intoxication, they may be pregnant. A big thing with this respiratory alkalosis we can see with pregnancy, because what happens is the uterus pushes up to the diaphragm, and it compresses up to the chest, and it kind of makes it harder for the lungs to expand. So the women that are pregnant, they breathe faster because that's their way of compensating for the anatomical changes that are occurring. Another thing we can also see with respiratory alkalosis if our ventilatory settings aren't changed. So this is why we do ABGs routinely, is because a lot of times if the rates are off and the gases aren't in sync with the vent settings, we may need to change them. Okay, so what do we see with some indications of respiratory alkalosis? You'll see numbness and tingling, inability to concentrate. You'll see loss of consciousness, you'll see tachycardia, and ventricle and atrial dysrhythmia. Okay, so there's a lack of CO2, so you're going to have an alteration, and see here that a lot of times if you see that you're losing CO2, you're going to see that you're going to lose, you're going to have a deficit in your potassium. Okay, so that's important. So when you're looking at, in terms of respiratory alkalosis, you're going to see an anxious patient. So what are you going to do? You're going to have them stop and breathe through a paper bag because you want them to rebreathe that CO2, right? You're going to have them calm down. You'll give them anti-anxiety medications. You'll give them Xanax to calm them down. If it's a patient on a ventilator, you'll slow down the rate on the ventilator. Respiratory acidosis is when there's an inadequate excretion of CO2. So there's too much CO2 and there's a low pH. And so what happens, usually we'll see patients with pulmonary edema, aspiration, atelectasis, like if they're in respiratory distress, you'll see that. Sleep apnea, a pneumothorax, anything altering the pulmonary system, you're going to see respiratory acidosis. So typically when we have too much CO2 in our blood, if that happens, it's a vasoconstrictor. So what happens is we're going to have increased pulse, respirations, blood pressure, altered confusion, fullness of the head, and altered level of consciousness. So this just kind of tells you where what respiratory acidosis is, okay? And so in turn, you're going to see hyperkalemia, okay? So you'll see decreased blood pressure with vasodilation, rapid shallow respiration, headache, dysrhythmias due to potassium. So all these different alterations and changes. So what happens when we do this? What do we try to do? The biggest thing is ventilation. So all the conditions we mentioned, they're all connected to the lungs. So what are the things we're going to do? We're going to use bronchodilators to kind of enhance and open up the airway. We can use pulmonary hygiene measures, push fluids, reposition patient frequently. But the most commonly things, these patients are most likely on the ventilator, so you're most likely going to have to adjust your ventilator settings. So if the patient has too much CO2 in their blood, we want them to breathe it off. So we're going to increase their ventilator rate. We're going to keep them in the semi-Fowler's position to kind of help them ease the work of the breathing and just kind of help them blow it off. Because the thing is we want to make sure that we do it slowly, because then it can cause a stress to the body. Before I forget, vomiting, gastric suction, and pyloric stenosis. Pyloric stenosis is where there is a narrowing of the pyloric sphincter, and it makes it harder. Usually the patients have frequent emesis. They have frequent emesis, and they lose a lot of electrolytes. So with pyloric stenosis, usually they'll need corrective surgery. So they'll always, before they're diagnosed, their ABG will come back with metabolic alkalosis. Okay. Some of the things that we want to do is we want to monitor intake and output, because they are vomiting, so they're losing electrolytes, and we're just going to push them with fluid. Okay, we'll give them normal saline fluids because we want to hydrate them, and we also want to make sure if there's a deficit in their potassium levels that we give them potassium chloride. Also, a lot of times too, what we'll do is we'll have H2 receptor antagonists, which are Tagamet, which kind of help us hold on to the hydrochloric acid so we don't lose it anymore. And so this is just a little picture of the metabolic alkalosis here. For metabolic alkalosis, you're going to see a pH that is elevated and a bicarb that's elevated, because metabolic moves in the same direction as pH. So what you're going to be seeing is restlessness, dysrhythmias, compensatory hypoventilation. Sometimes when your metabolic component is low or high, or when your respiratory component is low or high, sometimes it'll cause the opposite factor to get involved to compensate for either the decrease in the component or the increase in the component. So it's very likely that you might see that in a compensation effect as far as when you're looking at acidosis and alkalosis. But that'll be taught further in detail in advanced courses, but what you want to understand is the basics, okay? And so that's what that means. Compensatory hypoventilation is a way of the body responding to the low metabolic component, okay? So you'll have confusion, nausea, tremors, and you'll have hypokalemia, okay? So in some cases where a patient is maybe severely vomiting or in use of diuretics and fluid loss, if you're excessively deep suctioning a patient that maybe has a trach or is possibly is ventilated, you could see metabolic alkalosis with your patient. Metabolic acidosis is when there's a low pH and a low bicarb. And usually with, I have this reversed, I'm sorry, but usually when we have a loss of bicarb, it's usually diarrhea, if we're having too much output, or if the patient is like NPO and on fluids or on parenteral fluids and they're not getting enough sodium bicarb, or if we're giving too much chloride in our TPN, it can alter that. And so a lot of times, signs and symptoms, you'll see headache, confusion, drowsiness, increased respiratory rate, nausea, and vomiting. Okay, so what do we do for metabolic acidosis? The biggest thing is what we do is, first we have to see what the cause is. So if it's because we have too much chloride in our TPN, we're going to adjust our TPN. If it's a patient that is in shock and is in metabolic acidosis, we're going to give sodium bicarb. Okay, and then we're going to monitor potassium, because we know that with sodium bicarb, we're going to have alterations in potassium levels. A good thing to remember too with metabolic acidosis is that we're going to touch on this, but we typically see Kussmaul breathing, because when our body becomes, when we see metabolic acidosis, our body isn't reabsorbing the potassium, and so a lot of times if our kidneys are shutting down, they're not reabsorbing not the potassium, they're not reabsorbing the bicarb, and so what happens is the respiratory component gets involved, and so the breathing, the Kussmaul breathing occurs. Okay, and so it makes them breathe a little bit more shallow, so that it'll kind of compensate and create hyperventilation faster. Sorry, hyperventilation. Okay, diabetic ketoacidosis. The biggest thing we want to know about diabetic ketoacidosis is that it's the lack of insulin. Okay, diabetes is the lack of insulin, but DKA is worse, because there is just no sufficient amount of insulin for the intake that's occurring. Okay, and so what happens is we see severe hyperglycemia, and what happens is that because of the lack of insulin, we see dehydration and acidosis, and we'll explain about this. Okay, so how does DKA occur? Okay, so what happens is the body is lacking insulin. And so what happens is that the cells are not getting the sugar that they need. The sugar staying in the extracellular fluid. And so what happens is the body doesn't recognize that the fluid is, not the fluid, the body doesn't recognize that the sugar isn't going into the cell because of the insulin, it's just staying in the extracellular fluid, that the liver starts compensating and producing, releasing glycogen. Okay? And glycogen is used when we don't have, when we're going like into a hypoglycemic state, our liver compensates and releases sugar that's stored to kind of help and restore our blood sugar. So with DKA, our body is not recognizing that due to the insulin, the lack of insulin, our cells aren't getting the sugar, so let's get the liver involved. The liver gets involved, releases the glycogen, and what's released with the glycogen is what's called a keto acid. Okay, so what happens is because the cells are compromised of the sugar, the body tries to get rid of the excessive amount of glucose in the vasculature. So then the kidneys start urinating, the kidneys start producing urine, and so we see polyuria. And so because of the polyuria, we see dehydration. Okay? So when the fatty acids are converted into the ketone bodies, which is what the liver helps us do, due to the lack of insulin to take those ketone bodies into the cell, they stay in the blood. Okay? And so this makes the body acidotic, which leads to metabolic acidosis. So eventually what we end up seeing is metabolic acidosis, and with compensation of the respiratory system by breathing, by initiating Kussmaul breathing. Okay, so due to the metabolic acidosis, the potassium is not able to get, well, actually not even due to the metabolic, it's due to the lack of insulin. Potassium isn't able to get into the cell because it's housed into the cell. So a lot of times we'll see hyperkalemia with DKA. So we'll see ketones in the blood and the urine. We'll see electrolyte imbalances because we're losing a lot of fluid, and so we're essentially being dehydrated. Okay. We'll have low blood pressure because we're losing fluid. We're having polyuria, and patients are going to feel as great. They're going to feel very tired. They're going to have, feel discomfort, and they'll be nauseous and vomiting because of the high glucose. Actually, not because of that. Because of the low glucose in the cell. Because the glucose isn't in the cell, it's in the vasculature. So what do we do for the DKA? Because we're losing a lot of our fluid through urine, we're going to what? Replenish our fluid and our electrolyte balances. A lot of times we give them drips of insulin because the insulin will help regulate and put the sugar into the cell, and it also will help carry the potassium into the cell. A lot of times when we give the insulin and the fluid, acidosis corrects itself. So we want to make sure and pay really close attention to the acidosis portion of it, because usually it'll correct itself once we give the insulin and the fluid. We're going to monitor blood glucose levels. Because of the high glucose levels, we want to make sure, and the alteration, the compensation to our kidneys, we want to make sure we're checking the renal function. We also want to check for cardiac and electrolyte levels. Specific cardiac EKG, we want to be checking the potassium levels, because remember, potassium is housed in the cell, and so there's no insulin to carry it in there. We're going to be checking vital signs, lung assessments for any indications of fluid overload, because we are giving them fluid resuscitation.
In the concept of ethical legal is the exemplar Nurse Practice Act. The Nurse Practice Act is also under the Professional and Legal Regulation of Nursing Practice, as well as standards and credentialing. Nurses who practice safely respect both the voluntary and legal controls that map the boundaries of nursing practice. Within Nursing Practice Acts, each state is the most important law affecting the nursing practice. Each state has a Nurse Practice Act that protects the public by broadly defining the legal scope of nursing practice. You should obtain a copy of this act from your State Board of Nursing and study it carefully after you have received your license. Visit the website of the National Council of State Boards of Nursing for more information about Nurse Practice Acts and how to contact your State Board of Nursing. Each nurse is expected to care for patients within defined practice limits. Practicing beyond those limits makes you vulnerable to charges of violating the State Nurse Practice Act. Standards are also part of the professional and legal regulation of nursing practice. Voluntary standards developed and implemented by the nursing profession itself are not mandatory but are used as guidelines for peer review. Examples of voluntary standards include the American Nurses Association Standards of Practice, professional standards for the accreditation of education programs and service organizations, and standards for the certification of individual nurses in general and specialty areas of practice. Credentialing is the third professional and legal regulation of nursing practice. Credentialing refers to ways in which professional competence is ensured and maintained. The concept of ethical legal also has the exemplars criminal law, civil law. A crime is a violation punishable by the state, whereas a tort is subject to action in a civil court, with damages usually being settled with money. In a crime, criminal law is in most cases statutory law. Crimes are classified as misdemeanors or felonies. A misdemeanor is a less serious crime than a felony. Misdemeanors are commonly punishable with fines, imprisonment for less than 1 year or both, or with parole. A felony is punishable by imprisonment in a state or federal penitentiary for more than 1 year. Torts may be intentional or unintentional acts of wrongdoing. A person committing an intentional tort is considered to have knowledge of the permitted legal limits of his or her words or actions. Unintentional torts are referred to as negligence. A person who fails to initiate proper precautions to prevent patient harm, like falls or skin breakdown, is subject to the charge of negligence. Within intentional torts, you have assault and battery. Assault is a threat or an attempt to make bodily contact with another person without that person's consent. Battery is an assault that is carried out and includes willful, angry, and violent or negligent touching of another person's body or clothes, or anything attached or held by that other person. Defamation of character is an intentional tort in which one party makes derogatory remarks about another that diminish the other party's reputation. Slander is oral defamation of character. Libel is written defamation. Invasion of privacy includes all information about a patient being considered private or confidential, whether it be written on paper, saved on a computer, or spoken aloud. This includes their name and all identifiers such as address, telephone, fax number, social security number, and any other personal information. It also includes the reason the patient is sick or in the hospital, office, or clinic, the treatment he or she receives, and information about past health conditions. False imprisonment is unjustified retention or prevention of the movement of another person without proper consent and can constitute false imprisonment. For example, only a reasonable amount of restraint should be used in circumstances that warrant it. Fraud is willful and purposeful misrepresentation that could cause or has caused loss or harm to a person or property. Within unintentional torts, negligence and malpractice is libel. Negligence is defined as performing an act that a reasonably prudent person under similar circumstances would not do, or conversely, failing to perform an act that a reasonably prudent person under similar circumstances would do. Malpractice is the term generally used to describe negligence by professional personnel. We have elements of liability. Liability involves 4 elements that must be established to prove that malpractice or negligence has occurred. 1, duty, 2, breach of duty, 3, causation, and 4, damages. Last, we have standards of care. Whether negligence has occurred depends on a standard of care, what a reasonably prudent person would or would not have done under similar circumstances. All nurses are responsible for following the standards of care for their particular areas of practice. The concept of nutrition includes the exemplars obesity, malnutrition, iron deficiency anemia, dysphagia, cardiovascular, diabetes mellitus 2, malabsorption. Within the malabsorption, there is also gastrostomy and enteral feedings. The reading you are responsible for, and we will go over briefly the nutrition with the exemplars associated with it. Nutrition is important to maintain health and to prevent disease and death. When illness or injury occurs, optimal nutrition is essential for healing and for resisting infection and other complications. Components of a nutritional assessment, there is a sequence of assessment parameters that may vary. However, evaluation of nutritional status includes these following methods: measurement of body mass index, or the BMI, waist circumference, biochemical assessment, clinical examination findings, and dietary data. The measurement of BMI and waist circumference is recommended to determine if a patient is obese. The BMI ratio based on base body weight and height. The obtained value is compared to the established standards. The BMI is highly correlated with body fat, although increased lean body mass or a large body frame can also increase the BMI. In nutrition, it's important to consider lifespan considerations. Adolescence is a time of critical growth and when lifelong eating habits are established. Nutritional assessment is particularly important during this time period. It is vital to assess for obesity in adolescents to prevent complications from obesity as they enter adulthood. Adolescent girls are at a particular nutritional risk because iron, folate, and calcium intakes are below recommended levels, and they are less physically active group compared to adolescent males. Adolescents with other nutritional disorders such as anorexia and bulimia have a better chance of recovery if these disorders are identified and treated in the adolescent years rather than the adulthood. In nutrition, the older adult has a nutritional assessment that we must consider. Nutritional screening in the older adult is the first step in maintaining adequate nutrition and replacing nutrient losses to maintain the individual's health and well-being. Inadequate dietary intake in older adults may result from physiologic changes in the GI tract, socioeconomic factors, drug interactions, disease, and excessive use of alcohol, and poor dentition or missing teeth. Even well older adults may be nutritionally at risk because of decreased odor perception, poor dental health, limited ability to shop and cook, financial hardship, and the fact that they often eat alone. In addition, reduction in exercise with age without concomitant changes in carbohydrate intake places the older adult at risk for obesity. There is an increased need for good nutrition, but a decreased need for calories. They also have a decline in renal function and a decreased ability to maintain fluid and electrolyte balance. In nutrition, the exemplar malnutrition is a concern. There are health consequences that are associated with malnutrition: wound healing, susceptibility to infection, longer hospital stays, and prolonged confinement to bed. There are certain signs and symptoms that suggest possible nutritional deficiency, such as muscle wasting, poor skin integrity, loss of subcutaneous tissue, and obesity. These are easy to note because they are specific. Other physical signs may be subtle and must be carefully assessed. For example, certain signs that appear to indicate nutritional deficiency may actually reflect other systemic conditions, like endocrine disorders or infectious disease. Others may result from impaired digestion, absorption, excretion, or storage of nutrients in the body. Disorders caused by nutritional deficiency, overeating, or eating unhealthy meals are among the leading cause of illness and death in the United States today. Examples of health problems associated with poor nutrition include obesity, osteoporosis, cirrhosis, diverticulitis, and eating disorders. In the concept nutrition, we'll be discussing iron deficiency anemia. Anemia is a condition in which the hemoglobin concentration is lower than normal. It reflects the presence of fewer than normal number of erythrocytes within the circulation. As a result, the amount of oxygen delivered to body tissues is also diminished. Anemia is not a specific disease state, but a sign of an underlying disorder. Anemia can be classified in several ways. A physiologic approach classifies anemia according to whether the deficiency in erythrocytes is caused by a deficit in their production, by their destruction, or by their loss. In your textbook, page 901, Hinkle, you have a chart, table 33.1, that has a classification of anemias. We will be focusing on the iron deficiency. In a CBC with iron deficiency anemia, there is low MCV and low reticulocytes. Other findings are low iron, low percent of saturation, and low ferritin. With this, clinical manifestations include fatigue. Also pica. Pica is the persistent eating of substances with no nutrition, such as dirt or paint or even starch. Within the concept of nutrition, there is cardiovascular as an exemplar. See page 732 in your Hinkle textbook, chart 27.1, titled Risk Factors, Coronary Artery Disease. Now, there are non-modifiable risk factors, and there are modifiable risk factors. A non-modifiable risk factor is a circumstance over which a person has no control. A modifiable risk factor is one over which a person may exercise control, such as change in a lifestyle or personal habit, or by using medication. A risk factor may operate independently or in tandem with other risk factors. The more risk factors a person has, the greater the likelihood of coronary artery disease. Non-modifiable risk factors are family history of coronary artery disease, increasing age, gender, men develop coronary artery disease at an earlier age than women, and race, higher incidence of heart disease in African Americans than in Caucasians. Modifiable risk factors include hyperlipidemia, and within that, high low-density lipoprotein, smoking, hypertension, diabetes, metabolic syndrome, obesity, and physical inactivity. In the cardiovascular exemplar, prevention is essential. Controlling cholesterol abnormalities will benefit the patient in having less cardiovascular disease. The way we can control cardiovascular levels and the levels that we want is a low density lipoprotein, or LDL, a high density lipoprotein, HDL, low triglycerides, and a diet that has low saturated fat and high fiber. LDL is the target of current therapy because of its strong association with advancing coronary artery disease. The total cholesterol level is also a clear predictor of coronary events. High-density lipoprotein is known as good cholesterol because it transports other lipoproteins, such as low-density lipoproteins, to the liver, where they can be degraded and excreted. Because of this, a high HDL level is a strong negative risk factor for heart disease. It protects against heart disease. With continuing in the exemplar cardiovascular, prevention continues. Dietary measures. They provide recommendations of the therapeutic lifestyle changes diet, which is a diet low in saturated fat and high in soluble fiber. These general recommendations may need to be adjusted for the individual patient who has other nutritional needs, such as the patient who has diabetes. Physical activity is essential. Management of an elevated triglyceride level focuses on weight reduction and increased physical activity. Regular moderate physical activity increases HDL levels and reduces triglyceride levels, decreasing the incidence of coronary events and reducing overall mortality risk. Medications can be utilized if diet alone cannot normalize serum cholesterol levels. Medications can have a synergistic effect with the prescribed diet and control cholesterol levels. Lipid-lowering medications can reduce coronary artery disease mortality in patients with elevated lipid levels and in at-risk patients with normal lipid levels. Cigarette smoking contributes to the development and severity of coronary artery disease. A person who can have a cessation of smoking will decrease the risk for heart disease. Person at increased risk for heart disease is encouraged to stop tobacco use through any possible means, whether it be educational programs, counseling, consistent motivation, and reinforcement messages, support groups, and medications if needed. Managing hypertension is defined as blood pressure measurements that repeatedly exceed 140 over 90 millimeters of mercury. The risk of cardiovascular disease increases as blood pressure increases, and people with a blood pressure greater than 120 over 80 are considered pre-hypertensive and at risk. Early detection of high blood pressure and adherence to a therapeutic regimen can prevent the serious consequences associated with untreated elevated blood pressure, including coronary artery disease. Controlling diabetes is known to help prevent the development of heart disease. For many patients with diabetes, cardiovascular disease is identified as the cause of death. Hyperglycemia fosters dyslipidemia, increased platelet aggregation, and altered blood cell function, which can lead to thrombosis formation. These metabolic alterations may impair endothelial cell dependent vasodilation and smooth muscle function, promoting the development of atherosclerosis. The concept nutrition with the exemplar diabetes mellitus type 2 focuses on meal planning. Caloric requirements are based on age, gender, height, and weight, but the caloric distribution depends on carbohydrates, fats, proteins, and fiber. Carbohydrates should consist of 50 to 60% of the caloric requirements, fat 20 to 30%, protein 10 to 20%, and fiber 25 grams a day. With the concept of nutrition and the exemplar malabsorption, we'll be now discussing malabsorption with the infant or child. Short bowel syndrome is a clinical syndrome of nutrient malabsorption and excessive intestinal fluid and electrolyte losses that occurs following massive small intestinal loss or surgical resection. The most common causes of short bowel syndrome are necrotizing enterocolitis, small intestinal atresia, gastroschisis, malrotation with volvulus, and trauma to the small intestine. The extent of the malabsorption experienced by an individual is dependent upon the extent of the duodenal, ileal, or jejunal loss and the length of the small intestine loss, as well as the type. In malabsorption for the infant child with the short gut syndrome, nursing management includes total parenteral nutrition for long term, enteral feeding, administering vitamin and mineral supplements, administering antidiarrheals, and administering antibiotics per order. The child with short bowel syndrome is at risk for chronic complications. The goals of therapeutic management are to minimize bacterial overgrowth and to maximize the child's nutritional status. The antibiotics may be used to control that bacterial overgrowth. Vitamin and mineral supplementation is necessary because the small intestine is usually where fat-soluble vitamins, calcium, magnesium, and zinc are absorbed. Antidiarrheal agents such as loperamide and gastric acid suppressive medications may be used to decrease stool output. Many children with short bowel syndrome require total parenteral nutrition for extended periods to achieve adequate growth. Gastrostomy and enteral feedings are exemplar under nutrition. Gastrointestinal intubation is the insertion of a flexible tube into the stomach or beyond the pylorus into the duodenum or the jejunum. The tubes may be inserted through the mouth, the nose, or the abdominal wall. The tubes are obviously of various diameters and length depending on their intended use. The purpose of GI intubation may be performed in order to decompress the stomach and remove gas and fluid, lavage, which is flush with water or other fluids and remove ingested toxins or other harmful materials, diagnose GI disorders, administer tube feedings, fluids, and medications, compress a bleeding site, or aspirate GI contents for analysis. The different types of tubes depend on the diagnosis. Within these tubes, we do nursing management. We prepare the patient prior to the insertion to promote cooperation during the procedure. Once placed, we confirm placement. To ensure patient safety, it's essential to confirm the tube has been placed correctly. The tip of the tube may be in the esophagus, stomach, or small intestine. It may also inadvertently be inserted in the lungs, most commonly in the right main stem bronchus. Inappropriate placement may occur in patients with decreased level of consciousness, confused mental states, poor absent gag, or cough reflexes, or agitation during insertion. Also, what must be assessed is clearing tube obstruction. If it's difficult to instill withdrawal warm water into a clogged feeding tube, several declogging steps can be taken, including warm water penetration, milking the tube, infusing digestive enzymes, and employing mechanical declogging devices. When the tube is first noted to be clogged, a 30 to 60 ml syringe should be attached to the end of the tube and any contents aspirated and discarded. Then the syringe should be filled with warm water, attached to the tube again, and a back and forth motion initiated to help loosen the clog. Clearing tube obstructions is essential so that medications can be input or drainage can be expelled. Also, the nurse must provide oral and nasal hygiene. It is essential to have regular conscious oral and nasal hygiene because the tube causes discomfort and pressure and may be in place for an extended length of time. The nose is inspected daily for irritation and the tape is changed every 2 to 3 days. The nurse must also monitor and manage potential complications. Patients with these NG intubations are susceptible to a variety of problems, including fluid volume deficit, pulmonary complications, and tube-related irritations. These potential complications require careful ongoing assessment. There are also collaborative potential problems with gastrostomy and enteral feedings. There could be wound infections, whether it be wounds within the body or wounds at the site. Cellulitis, that is mostly at the site that there could be cellulitis of where the tube is inserted, whether it be nares, oral, or abdominal. Leakage at the site, gastrointestinal bleeding, and premature dislodgement of the tube. In the gastrostomy and enteral feedings, patient education is important. You can find a patient education chart, 45-7, page 1233, in your Hinkle ebook. Troubleshooting for mechanical difficulties is an intervention that should be utilized. Mechanical problems can arise with the infusion pump or catheter site. The patient should know the external length of the catheter, and the measurement is used as a comparison if dislodgement is suspected. The patient should also know a list of instructions on how to recognize catheter problems, including the leakage, loose caps, blood clots, and dislodgement, and what to do for each problem. Recognizing metabolic complications is essential. The patient is given a list of signs and symptoms that indicate metabolic complications like neuropathies, mentation changes, diarrhea, nausea, skin changes, decreased urine output, and directions on how to contact a home health care nurse or physician if these complications occur. Obtaining psychosocial support of home parental nutrition are as important as the physiologic and technical concerns, because the patients must cope with the loss of eating and with changes in lifestyle brought on by sleep disturbances related to frequent urination during nighttime infusions. So major psychological reactions include depression, anger, withdrawal, anxiety, impaired self-image, and a successful parenting nutrition program depends on the patient's and family's motivation, emotional stability, and technical competence. Within the concept of diversity has culture. Culture is part of the concept of diversity, and within culture, we have cultural influences on healthcare. In the United States, it is a multicultural, multi-ethnic, and multiracial. Therefore, nurses must be aware of and sensitive to the needs of a culturally diverse patient population. There are physiologic variations. Various studies have shown that certain racial and ethnic groups are more prone to developing specific diseases and conditions. For example, a hereditary disorder, Tay-Sachs disease, is associated with individuals of Eastern European Jewish descent. Another influence would be reactions to pain. Some cultures allow and even encourage the open expression of emotions experienced by a person in pain, whereas other cultures frown on the open and free expression of emotions. Within mental health, most mental health norms are based on research and observations made of white, middle-class people. Many ethnic groups have their own norms or acceptable patterns of behavior for psychological well-being and normal psychological reactions to certain situations. Within gender roles, there are many cultures where the man is the dominant figure and generally makes decisions for all family members. With language and communication, there are other people from other parts of the world that have moved to the United States. They may speak their own language fluently but have difficulty speaking English. This is especially true for the women or older adults in the family if they do not work outside the home, or for people who live in proximity to others who speak their primary language. With orientation to space and time, there are cultural influences in healthcare also. When providing nursing care that provides physical contact, you should know the patient's cultural personal space preferences. For example, people of Arabic and African origin commonly sit and stand close to one another when talking, whereas people of Asian and European descent are more comfortable with some distance between themselves and others. Food and nutrition, cultural influences, deal with patients in a hospital or long-term care setting often not having much choice of foods. This means that people with cultural food preferences may not be able to select appealing foods and thus may be at risk for inadequate nutrition. Family and support. In many cultural and ethnic groups, people have large extended families and consider the needs of any family member to be equal to or greater than their own. Within socioeconomic factors, poverty has been a long time barrier to adequate health care. It prevents many people from consistently meeting their basic human needs. Within the concept of diversity, the exemplar is complementary and alternative medicine, or abbreviated CAM. Complementary medicine is used together with conventional medicine, such as using aromatherapy to reduce discomfort after surgery or to reduce pain during a procedure or during early labor. Alternative medicine is used in place of conventional medicine, such as eating a special natural diet to control nausea and vomiting or to treat cancer instead of undergoing surgery, chemotherapy, or radiation that has been recommended by a conventional doctor. Integrative medicine combines mainstream medical therapies and CAM therapies for which there is some scientific evidence of safety and effectiveness. These include acupuncture, reflexology, therapeutic touch, meditation, yoga, herbal therapies, nutritional supplements, homeopathy, naturopathic medicine, and many more used for the promotion of health and well-being. The nurse's role in CAM would be culturally sensitive to non-traditional treatments, acknowledge and respect different beliefs, attitudes, and lifestyles, keep an open mind, accept CAM and integrate it if it brings comfort without harm, provide accurate information, not your opinion, advise clients how they can best monitor their condition, discourage practices only if they are harmful to the client, instruct the client to weigh the risks and the benefits of the CAM use, avoid confrontation when asking clients about their CAM, and be reflective, non-judgmental, and open-minded. The first concept of metabolism includes, within all of your reading on the reading assignment list, diabetes type 1, diabetes type 2, gestational diabetes, hyperthyroidism with a focus on Graves' disease, hypothyroidism, hypercortisolism, which is Cushing's disease, and hypocortisolism, which is Addison's disease. The concept of metabolism concerning the exemplar diabetes mellitus, which is classified into different types. There is diabetes type 1, diabetes type 2, gestational diabetes, and diabetes associated with other conditions or syndromes. For example, a woman with gestational diabetes may, after delivery, move into the diabetes mellitus type 2 category. Prediabetes is classified as impaired glucose tolerance or impaired fasting glucose and refers to a condition in which blood glucose concentrations fall between normal levels and those considered diagnostic for diabetes. Now, insulin is the hormone secreted by the beta cells, which are one of the 4 types of the islets of Langerhans in the pancreas. Insulin is an anabolic or storage hormone. And when a person eats a meal, insulin secretions increases and moves glucose from the blood into the muscle, liver, and fat cells. In those cells, insulin has the following actions: transport and metabolizes glucose for energy, stimulates storage of glucose in the liver and muscle in the form of glycogen, and signals the liver to stop the release of glucose. Now, there are risk factors for diabetes mellitus. First is the family history of diabetes. Second, obesity. Third, race and ethnicity with African Americans and Hispanic Americans, Native Americans, Asian Americans, and Pacific Islanders. Age greater than 45, but that doesn't always consider the same as the type 1 diabetes mellitus. Previously identified impaired fasting glucose or impaired glucose tolerance tests, which has to do with gestational diabetes. Hypertension greater than 140 systolic. High density lipoprotein cholesterol levels or triglyceride levels, and history of gestational diabetes or delivery of a baby over 9 pounds. Now, within this type 1 diabetes mellitus, there are some symptoms, clinical manifestations that will be found. One is polyuria, which is frequent urination. Second is polydipsia, which is excessive thirst. And third is polyphagia, which is excessive hunger. These individuals will drink, eat, and urinate, and they don't understand why. It's because their body is asking them to do those things to get the glucose in their cells and energy, and it's not going to work. So they end up with weight loss, they end up with fatigue, and they end up with weakness. With type 2 diabetes, it affects approximately 90 to 95% of people with the actual diabetes disease. It occurs more commonly in young people who are older than 30 years of age and obese. There are 2 main problems related to the insulin in type 2 diabetes are insulin resistance and impaired insulin resistance. Normally, a person without disease, insulin binds to special receptors on cell surfaces and initiates a series of reactions involved in glucose metabolism. In type 2 diabetes, these intracellular reactions are diminished, making insulin less effective at stimulating glucose uptake by the tissues and at relating glucose release by the liver. Now, the exact mechanism that leads to insulin resistance and impaired insulin secretion in type 2 diabetes are unknown, although genetic factors are thought to play a key role. So the patient's pancreas continues to produce some endogenous insulin, and the insulin produced is insufficient or is poorly utilized by the tissues. For type 2 diabetes, obesity is the most powerful risk factor. For most patients, type 2 diabetes is detected incidentally. One consequence of undetected diabetes is that long-term diabetes complications such as eye disease, peripheral neuropathy, peripheral vascular disease may have developed before the actual diagnosis of diabetes is made, signifying that the blood glucose has been elevated for a time before diagnosis. Type 2 diabetes is associated with a slow progressive glucose intolerance, and its onset might go undetected, as I stated, for many years. If the patient's symptoms are experienced, they are frequently mild and may include the fatigue, irritability, polyuria, polydipsia, and poorly healing skin wounds, vaginal infections, or blurred vision if glucose levels are very high. Now, once again, this may be also the etiology and pathology from genetic mutations, as we stated earlier, that led to insulin resistance, and once again, that increased risk for obesity. For both type 1 and type 2 diabetes mellitus, the nursing and collaborative management care goal is to normalize insulin activity and blood glucose levels to reduce the development of vascular and neuropathic complications. The patient's goals are also for diabetes management to achieve normal blood glucose levels without hypoglycemia while maintaining a high quality of life. Therefore, diabetes management has 5 components: nutrition therapy, exercise, monitoring, pharmacologic therapy, and education. It involves constant assessment and modification of the treatment plan by health professionals and daily adjustments in therapy by the patient. Although the healthcare team directs the treatment, it is the individual patient who must manage the complex therapeutic regimen. Therefore, patient and family education is an essential component of diabetes treatment and is as important as all other components of the regimen. For both type 1 and type 2 diabetes, during periods of physiologic stress such as surgery, blood glucose levels tend to increase because levels of stress hormones, which are epinephrine, norepinephrine, glucagon, cortisol, and growth hormone, increase. If hyperglycemia is not controlled during surgery, the resulting osmotic diuresis may lead to excessive loss of fluids and electrolytes. Patients with type 1 diabetes are also at risk for developing ketoacidosis during periods of stress. During the postoperative period, patients with diabetes must also be closely monitored for cardiovascular complications because of the increased prevalence of atherosclerosis, wound infections, and skin breakdown. What must be maintained is adequate nutrition and blood glucose control to promote the wound healing. With clinical management of type 1 and type 2 diabetes, primary prevention is essential. It is also the management if you do have type 1 or type 2 diabetes. The areas of focus would be diet, exercise, and weight control. Nutritional, meal planning, and weight control and increased activity are the foundation of diabetes management. The most important objectives in the dietary and nutritional management of diabetes are control of total caloric intake to attain or maintain a reasonable body weight, control of blood glucose levels, and normalization of lipids and blood pressure to prevent heart disease. Success in this area alone is often associated with reversal of hyperglycemia in type 2 diabetes. For exercise, what the main goal would be is to manage diabetes because of its effects of lowering blood glucose and reducing cardiovascular risk factors with exercise. Exercise lowers those blood glucose levels by increasing the uptake of glucose by body muscles and by improving insulin utilization. It also improves circulation and muscle tone. Resistance training, such as strength training, weightlifting, can increase lean muscle mass, thereby increasing the resting metabolic rate. These effects are useful in diabetes in relation to losing weight, easing stress, and maintaining a feeling of well-being. Now, there are some considerations for exercise in people with diabetes. They can exercise 3 times each week with no more than 2 consecutive days without exercise. They can exercise at the same time of each day and the same duration for each session. Important to use proper footwear and, if appropriate, protective equipment. Avoid trauma to the lower extremities, especially in patients with numbness due to peripheral neuropathy. Inspect the feet daily after exercise. Avoid exercise in extreme heat or cold, and avoid exercise during periods of poor metabolic control. In people with type 2 diabetes who are overweight or obese, exercise in addition to dietary management improves glucose metabolism and enhances loss of body fat. Exercise coupled with weight loss improves insulin sensitivity and may decrease the need for insulin or oral anti-diabetic agents. Eventually, the patient's glucose tolerance may return to normal. For type 1 diabetes, the meal plan must consider the patient's food preferences, lifestyle, usual eating times, ethnic and cultural backgrounds. Patients who require insulin to help control blood glucose levels, maintaining as much consistency as possible in the amount of calories and carbohydrates ingested at each meal is essential. In addition, consistency in the amount time intervals between meals with the addition of snacks if necessary helps prevent hypoglycemic reactions and maintain overall blood glucose control. Blood glucose monitoring is a cornerstone of diabetes management, and self-monitoring of blood glucose levels has dramatically altered diabetes care. For type 1 diabetes, exogenous insulin must be administered for life because the body loses the ability to produce insulin. Consistently following a meal plan is one of the most challenging aspects of diabetes management. It may be more realistic to restrict calories only moderately. For patients who have lost weight, incorporating new dietary habits into their lifestyles, diet education, behavioral therapy, group support, and ongoing nutrition counseling are encouraged to maintain weight loss. In type 2 diabetes, insulin may be necessary on a long-term basis to control glucose levels if meal planning and oral agents are ineffective or when insulin deficiency occurs. In addition, some patients in whom type 2 diabetes is usually controlled by meal planning alone or by meal planning and an oral anti-diabetic agent may require insulin temporarily during illness, infection, pregnancy, surgery, or some other stressful event. People with type 2 diabetes who are overweight or obese, exercise in addition to dietary management both improves glucose metabolism and enhances loss of body fat. Exercise coupled with weight loss improves insulin sensitivity and may decrease the need for insulin or oral anti-diabetic agents. Calorie-controlled diets are planned by first calculating a person's energy needs and caloric requirements based on age, gender, height, and weight. Patients may be underweight at the onset of type 1 diabetes because of rapid weight loss from severe hyperglycemia. The goal initially may be to provide a higher calorie diet to regain lost weight and blood glucose control. The recommended level for caloric intake is 50 to 60% of calories should be derived from carbohydrates, 20% to 30% from fat, and the remaining 10% to 20% from protein. Carbohydrates. The caloric distribution currently recommended is higher in carbohydrates than in fat and protein. In general, carbohydrate foods that have the greatest effect on blood glucose levels because they are more quickly ingested than other foods and are converted into glucose rapidly. Carbohydrates consist of sugars and starches. Low glycemic index diets may reduce postprandial glucose levels. Therefore, the nutrition guidelines recommend that all carbohydrates should be eaten in moderation to avoid high postprandial blood glucose levels. Foods high in carbohydrates, such as sucrose, are not totally eliminated from the diet, but should be eaten in moderation because they are typically high in fat and lack vitamins, minerals, and fiber. The recommendations regarding fat content of the diabetic diet include both reducing the total percent of calories from fat sources to less than 30% of total calories and limiting the amount of saturated fats to 10% of total calories. Regarding protein, The meal plan may include the use of some non-animal sources of protein, like legumes and whole grains, to help reduce saturated fat and cholesterol intake. Hyperthyroidism, a common endocrine disorder, is a form of thyrotoxicosis resulting from an excessive synthesis and secretion of endogenous or exogenous thyroid hormones by a thyroid. The most common cause is Graves' disease. Graves' disease is the most common cause of hyperthyroidism. It is an autoimmune disorder that results from excessive output of thyroid hormones caused by abnormal stimulation of the thyroid gland by circulating immunoglobulins. This disease affects women 8 times more frequently than men, with onset usually between the 2nd and 4th decades. This disorder may appear after an emotional shock, stress, or an infection, but the exact significance of these relationships is not understood. The presenting symptom is often nervousness. These patients are often emotionally hyperexcitable, irritable, and apprehensive. They cannot sit quietly, and they suffer from palpitations. Their pulse is abnormally rapid at rest, as well as on exertion. They tolerate heat poorly and perspire unusually freely. The skin is flushed continuously, with the characteristic salmon color in Caucasians, and is likely to be warm, soft, and moist. A fine tremor of the hands may be observed, and patients exhibit exophthalmos, which is abnormal protrusion of one or both eyeballs, or as we call it, bulging eyes. Other manifestations include an increased appetite and dietary intake, weight loss, fatigability and weakness, amenorrhea, and changes in bowel function. In hyperthyroidism, medical management depends on the underlying cause and often consists of a combination of therapies, including antithyroid agents, radioactive iodine, and surgery. The treatment of hyperthyroidism is directed toward reducing the thyroid hyperactivity to relieve symptoms and preventing complications. The use of radioactive iodine is the most common form of treatment for Graves' disease. Beta-adrenergic blocking agents, like propanol or atenolol, are used as adjunctive therapy for symptomatic relief, particularly in transient thyroiditis. Surgical removal of the entire thyroid gland or part of it is a non-pharmacological agent. The 3 treatments, radioactive iodine therapy, antithyroid medications, and surgery, share the same complications: relapse or recurrent hyperthyroidism and permanent hypothyroidism. A nursing intervention is also improving nutritional status. Hypothyroidism affects all body systems, including the GI system. The appetite is increased, but may be satisfied by several well-balanced meals of small size, even up to 6 meals a day. Fluid and foods are selected to replace fluid loss through diarrhea and diaphoresis, and to control the diarrhea that results from increased peristalsis. Rapid movement of food through the GI tract may result in nutritional imbalance and further weight loss. To reduce diarrhea, highly seasoned foods and stimulants such as coffee, tea, and cola and alcohol are discouraged. High-calorie, high-protein foods are encouraged. The clinical manifestations of hypothyroidism are many. Extreme fatigue makes it difficult for the person to complete a full day's work or participate in usual activities. There are reports of hair loss, brittle nails, and dry skin are very common, and numbness and tingling of the fingers may occur. On occasion, the voice may become husky and the patient may complain of hoarseness. Menstrual disturbances, such as menorrhagia or amenorrhea, may occur. Hypothyroidism affects women more frequently than men and occurs most often between ages 40 to 70 years of age. Severe hypothyroidism results in subnormal body temperature and pulse rate. The patient usually begins to gain weight even without increase in food intake, although he or she may be cachectic. The skin becomes thick, the hair thins and falls out, and the face becomes expressionless and mask-like. The patient often complains of being cold, even in a warm environment. The patient may be irritable and complain of fatigue, but as the condition progresses, the emotional responses are subdued. The mental process becomes dulled, and the patient appears apathetic. Speech is slow, the tongue enlarges, the hands and feet increase in size, and even deafness may occur. The patient frequently complains of constipation. Severe hypothyroidism is associated with elevated serum cholesterol level, atherosclerosis, coronary artery disease, and poor left ventricular function. The patient with hypothyroidism that is advanced is hypothermic and abnormally sensitive to sedative, opioid, and anesthetic agents, which must be administered with extreme caution. Patients with unrecognized hypothyroidism who are undergoing surgery are at increased risk for intraoperative hypotension, postoperative heart failure, and altered mental status. Causes of hypothyroidism include autoimmune disease, like Hashimoto's thyroiditis or post-Graves' disease, atrophy of the thyroid gland with aging, therapy for hyperthyroidism, which would include radioactive iodine or thyroidectomy, medications which include lithium, iodine compounds, or antithyroid medications, procedures such as radiation to head and neck and treatment for head and neck cancers, like lymphoma, can also produce hypothyroidism. Infiltrative diseases of the thyroid can also cause hypothyroidism. And then, of course, iodine deficiency and iodine excess can cause hypothyroidism. Treatment for hypothyroidism includes the medical management with the objectives of hypothyroidism to restore a normal metabolic state by replacing the missing hormone, as well as prevention of disease progression and complications. Synthroid or levothyroid is commonly prescribed for treating hypothyroidism and suppressing non-toxic goiters. Its dosage is based on the patient's serum thyroid-stimulating hormone concentration. If replacement therapy is adequate, the symptoms of myxedema disappear and normal metabolic activity is resumed. Although rare, if the disease progresses to myxedema coma, IV administration of T4 and T3 are recommended rather than T4 alone. T4 is administered IV until the patient is able to safely take T4 in oral form. T3 is administered IV until the patient is stable. Administration of high-dose glucocorticoids every 8 to 12 hours for 24 hours, followed by a low-dose therapy is recommended until coexisting adrenal insufficiency is ruled out. Prevention of cardiac dysfunction is important, as well as prevention of medication interactions. Oral thyroid hormones interact with many other medications. There is a decrease in thyroid hormone absorption when patients are taking magnesium-containing antacids. Thyroid hormones may also decrease the pharmacological effects of digitalis. Doses of anticoagulant agents need to be decreased when beginning thyroid replacement because of the increased risk of bleeding. Even in small IV doses, hypnotic and sedative agents may induce profound somnolence, lasting far longer than anticipated and leading to narcosis. In adrenal hormone excess, there is Cushing's syndrome. They call it hypercortisolism. Now, the causes are results from excessive rather than deficient adrenocortical activity. Cushing's syndrome is commonly caused by the use of corticosteroid medications and is infrequently the result of excessive corticosteroid production secondary to hyperplasia of the adrenal cortex. However, overproduction of endogenous corticosteroids may be caused by several mechanisms, including a tumor of the pituitary gland that produces adrenocorticotropic hormone and stimulates the adrenal cortex to increase its hormone secretion despite production of adequate amounts. Primary hyperplasia of the adrenal glands in the absence of pituitary tumor is less common. Another less common cause of Cushing's syndrome is the ectopic production of the adrenocorticotropic hormone by malignancies. Regardless of the case, the normal feedback mechanisms that control the function of the adrenal cortex become ineffective, and the usual diurnal pattern of cortisol is lost. Signs and symptoms of Cushing's syndrome are primarily a result of oversecretion of glucocorticosteroids and androgens, although mineral corticosecretion may be affected as well. Clinical presentation can be obesity, hyperglycemia, glycosuria, hypertension, fluid and electrolyte disturbances, and may have psychosocial issues due to the body image. Clinical manifestations include when overproduction of the adrenal hormone occurs, arrest of growth, obesity, and musculoskeletal changes occur along with glucose intolerance. The classic picture of Cushing's syndrome in the adult is that of a central type obesity with a fatty buffalo hump in the neck and supraclavicular areas, a heavy trunk, and relatively thin extremities. The skin is thin, fragile, and easily traumatized. Ecchymosis and striae developed. The patient complains of weakness. Sleep is disturbed because of altered diurnal secretion of cortisol. Excessive protein catabolism occurs, producing muscle wasting and osteoporosis. Kyphosis, backache, and compression fractures of the vertebrae may result. Retention of sodium in water occurs as a result of increased mineralocorticoid activity, producing hypertension and heart failure. The patient develops a moon-faced appearance and may experience increased oiliness of the skin and acne. Hyperglycemia or overt diabetes may result. The patient may also report weight gain, slow healing of minor cuts and bruises. In females of all ages, virilization may occur as a result of excess androgens. If Cushing's syndrome is caused by pituitary tumors rather than tumors of the adrenal cortex, treatment is directed at the pituitary gland. Surgical removal of the tumor is the treatment of choice and has an 80% success rate. Radiation of the pituitary gland also has been successful. Adrenalectomy is the treatment of choice in patients with primary adrenal hypertrophy. Adrenal enzyme inhibitors such as metoprolol, cytodren, and lisodren may be used to reduce hyperadrenalism if the syndrome is caused by the ectopic ACTH secretion by a tumor that cannot be eradicated. If Cushing's syndrome is a result of administration of corticosteroids, an attempt is made to reduce or taper the medication to the minimum dosage needed to treat the underlying disease process. Also, what is included is a nursing intervention for decreasing risk of injury, preventing the falls and fractures or other injuries to bones and soft tissues. Foods high in protein, calcium, and vitamin D are recommended to minimize muscle wasting and osteoporosis. Decreasing risk of infection is a nursing intervention, meaning the patient should avoid unnecessary exposure to others with infections. Preparing the patient for surgery if the patient is going for an adrenalectomy if indicated, and the postoperative course. If Cushing's syndrome is a result of a pituitary tumor, a transsphenoidal hypophysectomy may be performed. Diabetes and peptic ulcer are common in patients with Cushing's syndrome. Therefore, insulin therapy and medication to prevent or treat peptic ulcer are initiated if needed. Encouraging resident activity is an important nursing intervention. Although the patient with Cushing's syndrome experiences insomnia, weakness, fatigue, and muscle wasting, the nurse should encourage moderate activity to prevent complications of immobility and produce increased self-esteem. Promoting skin integrity with meticulous skin care is necessary to avoid traumatizing the patient's fragile skin. Improving body image, if treated successfully, with the major changes associated with Cushing's syndrome disappear in time. The patient may benefit from discussion of the effect of the change that has had on their self-esteem concept and relationship with others. With hypocorticosolism, or Addison's disease, it's an adrenal cortical insufficiency. It occurs when adrenal cortex function is inadequate to meet the patient's need for cortical hormones. Autoimmune or idiopathic atrophy of the adrenal glands is responsible for the majority of cases. Other causes include surgical removal of both adrenal glands and infection of the adrenal glands. Tuberculosis and histoplasmosis are the most common infections that destroy adrenal gland tissue. Although autoimmune destruction has replaced tuberculosis as the principal cause of Addison's disease, tuberculosis should be considered in the diagnostic workup. Therapeutic use of corticosteroids is the most common cause of adrenocortical insufficiency. Symptoms of adrenocortical insufficiency may result from the sudden cessation of exogenous adrenocortical hormone therapy, which suppresses the body's normal response to stress and interferes with normal feedback mechanisms. The clinical manifestations with Addison's disease is characterized by muscle weakness, anorexia, GI symptoms, fatigue, emaciation, dark pigmentation of the mucous membranes and the skin, especially of the knuckles, knees, and elbows, hypotension, and low blood glucose, low serum sodium, and high serum potassium levels. Depression, emotional liability, apathy, and confusion are present in about 20 to 40% of patients. In severe cases, the disturbance of sodium-potassium metabolism may be marked by depletion of sodium and water and severe chronic dehydration. As the disease progresses, Addisian crisis develops. This condition is characterized by hypotension, cyanosis, fever, nausea, vomiting, and classic signs of shock. The patient may have pallor, complain of headache, abdominal pain, and diarrhea, and may show signs of confusion and restlessness. The treatment and medical management is directed towards combating circulatory shock, restoring blood circulation, administering fluids and corticosteroids, monitoring vital signs, and placing the patient in a recumbent position with legs elevated. Hydrocortisone, or Solu-Cortef, is administered by IV, followed by a 5% dextrose and normal saline. Antibiotics may be administered if infection has precipitated adrenal crisis. Oral intake may be initiated as soon as tolerated. IV fluids are gradually decreased after oral fluid intake is adequate to prevent hypovolemia. If the adrenal gland does not regain function, the patient needs lifelong replacement of corticosteroids and mineralocorticoids to prevent recurrence of adrenal insufficiency. During stressful procedures or significant illness, additional supplemental therapy with glucocorticoids is required to prevent Addison crisis. In addition, the patient may need to supplement dietary intake with salt during GI losses of fluids through vomiting and diarrhea. Health promotion is the concept and obesity is the exemplar. Promoting nutrition is important to educate to decrease obesity. Nutritional needs are increased during adolescence, though, due to accelerated growth and sexual maturation. Adolescents may appear to be hungry constantly and need regular meals and snacks with adequate nutrients to meet the body's anaerobic requirements. Multiple factors influence the adolescent's diet and eating habits. Now, there are nutritional needs for teenagers. They have a need for increased calories, zinc, calcium, and iron for growth. However, the number of calories needed for adolescents depends on the teen's age and activity level as well as growth patterns. Promoting healthy eating habits will last into the lifetime. The nurse understands normal growth and development of the adolescent and provides guidance that fits the quest for independence and the need for teens to make their own choices. They assess eating habits and diet preferences for the adolescent. The assessment should include evaluation of food from different food groups that the adolescent eats each day. There also should be prevention of developing of overweight and obesity. Although obesity has increased in all segments of the U.S. population, there are differences specific to race, ethnicity, and socioeconomic status. The prevalence of obesity is highest in Hispanic and African American teens between the ages of 12 and 19 years. But the increase in obesity in adolescents has led to increases in hypertension, heart disease, and type 2 diabetes. Influential factors causing obesity include food choices, eating practices, and lack of exercise. Research has indicated that the percentage of children that eat breakfast decreases with age, and that by adolescence, only 77% of 12 to 19-year-olds even eat breakfast. This runs also into being an adult. So to help with decreasing obesity, nurses need to be aware to teach factors that lead to obesity. And nurses should be recommending keeping a food diary to determine current food patterns, proper nutrition and healthy food choices, good eating habits, decreasing fast food intake, having patients participate in physical activity every day. Parents and adolescents together can be exercising more at home, and decrease computer use and television watching. Health information technology concept involves nursing informatics. Nursing informatics is a specialty that integrates nursing science, computer science, and information science to manage and communicate data, information, and knowledge in nursing practice. Nursing informatics facilitates the integration of data, information, and knowledge to support patients, nurses, and other providers in their decision-making in all roles and settings. As more nurses become informaticists, we are beginning to see tangible benefits of their efforts. It increases in the accuracy and completeness of nursing documentation. It has an improvement in the nurse's workflow and an elimination of redundant documentation. It has automation of the collection and reuse of nursing data and facilitation of the analysis of clinical data.
Okay, I'm finally done. I hope this works. Best of luck on your exam.